Welcome. Today we are going to talk about value-based care in rural America. One of the questions that we want to answer is, why is there so much focus on value-based care? It seems like you can't pick up a journal article these days without seeing something about value-based care. And so we are here to try to explain what it is, what it isn't, and how you can get in the game. So let's talk about, why we're doing this in the first place. Well, one of the problems is the way that we are delivering healthcare in this country isn't working. US healthcare is super expensive. We are 17% higher or 17% more of the GDP compared to other developing nations. Our outcomes are not as good. You can see that we have a big gap in our life expectancy compared to other developing nations. Our maternal mortality rate is worse, etc. So add to that the experiences for both clinicians and patients is below par. So it does seem like something's got to give. Well, one of the solutions to those problems that the Center for Medicare and Medicaid Services has posed is, is the answer value-based care? And so CMS has set a bold aim. They did this in October of 2021, and that aim is to have all of their beneficiaries in an alternative payment model by 2030. Well, 2030 will be here before we know it. And so what this means is this is a big move away from fee for service. In other words, when we're paid for every single patient we see, and the move now is to paying for value. In other words, high quality. Think of that in terms of outcomes, preventive care, chronic disease management, and doing so at a lower cost. Many of you have heard of the triple aim that was developed by the Institute for Healthcare Improvement. It's been expanded to the quadruple aim, and it simply says that value-based care means better health outcomes, a better patient experience, a better provider experience, and a reduced cost of care. So everything that we should be doing as clinicians as we move toward value-based care should really be serving one of these four objectives. Well, value-based care is a word that I think a lot of people use to mean a lot of different things, and this slide demonstrates why there is so much confusion. So we're going to walk through this briefly to just sort of demystify some of value-based care. So if you look at the bottom left-hand corner, you see fee-for-service. This is the world that we're living in right now. This is that we are being incentivized for volume, not for value. We are being paid based on the number of patients we see in any given day. Well, if you move all the way to the top of this slide, over on the far right-hand side, you can see global payments. Well, global payments are these fully capitated payments. So what happens is instead, what we get paid based on the total number of people that we have in our practice, and based on how sick they are, we would get paid more for sick patients and less for patients who are well. Well, there are a lot of things in between these two extremes. If you go back to sort of the bottom left, there's pay for performance, where we're actually getting, and maybe some of you are doing this, you're getting paid for completing mammograms or completing annual wellness visits or completing a certain percentage of, childhood immunizations or whatever, but you're being paid to perform on certain measures. Moving up to the next level, they're bundled payments. So this is when, take for instance, an orthopedic surgeon who does knee replacements. Instead of getting paid for every little piece of that procedure, he gets a global payment, and it's up to him or her to make sure that they are being efficient with, the length of the hospital stay and the supplies that they use, and that they don't end up with patients getting readmitted for infection, etc. In the next bucket are shared savings. Maybe some of you are doing this with some of the health plans. This is when they say, we're going to give you a certain set of measures and targets. And over the course of a year, we want to see how you perform. And if the care that you provided was high quality and the cost was lower than it was before, then that money that's left over, we're going to share between us, the health plan, and you, the provider. And this is a shared savings model. Well, shared risk is a little bit like shared savings, but the difference there is, well, if you don't do well, it's not just a simple matter of there were no shared savings, but then there would actually be some payback for inefficient care. So you can see there's a wide variety. So when people just say value-based care, they can mean any of these things. So what does it take to be successful in value-based care? Well, there are a lot of pieces to this puzzle. And so if we start at the top left-hand side of the screen, there are data and analytics. So what does this mean? Well, we have to know who our patient population is in the first place. So do I have a lot of frail elderly patients who are sick? Do I have a lot of, well patients? Are my patients economically disadvantaged such that they're less likely to get care based on insurance coverage, et cetera. So we need to be able to risk stratify our patients so that we can know, let's say I have 1,000 patients in my practice, are 100 of those patients super sick? Is it only 10? Is it closer to 250 of those patients? And then accordingly, I need to think about resourcing my practice to, in other words, adjust it to fit to the patient profile that I have. That's not how we do it today. We hire extra team members. We see patients who come in the office. Even though we schedule follow-up visits, it still often is reactive care in that we aren't doing a lot of this care between the visits, but rather are reacting to patients when they're in the office. That's a key difference between fee-for-service and value-based care. Moving over to the right, in sort of the gold puzzle piece there, you see risk-based contracting. So this is complicated. We are going to have to learn how to contract with health plans so that we ensure that the incentives are aligned with our ability to perform. It can be very complicated, deciding how are patients going to be attributed to us. Is it based on how frequently they see us? Is it based on who they identify as their PCP, et cetera? So learning the nuance of how to contract with payers. Sort of the dark sort of red wine colored box at the top right hand corner, workflows embedded into day-to-day care. Well, this is saying that, we've got to make sure that in this new world, when we're going to be doing telephonic visits, when we're going to be patients who just come in to see maybe educators or navigators who can help patients with their social determinants of health. We've got to rework all of our workflow so that it isn't simply a patient who comes to the front desk, gets checked in, gets roomed by a nurse, sees a doctor, and then leaves again. Right? We got to think about how do we get new members of the care team involved? Where do they work in the office? How much outreach are they doing into the community? And what does the workflow look like? Dropping down to the middle left, the staffing model aligning with the incentives. Not only are we going to have an expanded care team in value-based care, but there should be some behavioral economics. In other words, if we perform really well on certain measures, and it was because of the activities performed by the referral staff or by the population health team or by the diabetic educators, are there incentives to keep them motivated in the work that they're doing? And then key in the middle of this entire puzzle is, patients having access to us and making sure that this entire business stays relationship driven. In other words, often patients are, sitting around wringing their hands, waiting on their 3-month follow-up with a laundry list of questions that they need answered. Well, instead, we should have capacity to see those patients who are sicker, not only on demand, but for longer visits. And value-based care, since we're moving away from this world where we're paid simply for 15-minute healthcare when we're seeing patients every 15 minutes, instead, because of the way we'll be paid in value-based care, we can spend longer time with our patients who are sicker. Network relationships. This now becomes a world in which we have to think more carefully about the specialist to whom we refer our patients. In other words, if we have surgeons or other specialists who do not have high quality, they do have a high infection rate. Their patients do end up getting readmitted frequently. We want to steer clear of those clinicians. We want to make sure instead that we're sending our patients, not only for the patient's health and well-being, but because now we're thinking for the first time about being totally responsible for not only the cost of care within the walls of our clinic, but the total cost of care wherever that patient is out in the whole healthcare landscape. And then across the bottom row, you see, there's an obvious cultural change that will have to happen. We're going to have key performance indicators, KPIs, that are different than they've been before. And we really have to make sure we retain our patients. So much of our payment will be dependent on having a panel to support the care team that we need. In other words, if I have health navigators and patient advocates and care coordinators and educators, et cetera, but I only have a couple hundred patients in my practice, well, I can't sustain that. But once I risk stratify my patients, if they are very sick patients, suddenly we're living in a world where I am receiving money based on my total volume of patients. And if they're sicker, I receive more. If they're well, I receive less. Well, this makes perfect sense. I'm going to need to see the sicker patients more. If patients are well and all they really need is an annual checkup, and otherwise we can call in their medications, they can stop by and get labs when they need it. There are no disincentives for managing patients that way either. So let's talk about Main Street Health. I'm the Chief Medical Officer for Main Street Health. We built this business to address all of the topics that we've discussed thus far. And we built this business to provide a glide path for you, for all of your rural health care dilemmas. We're trying to solve those through our partnership model. So there's sort of three key pillars here. First, we're partnering with existing infrastructure. In other words, we do not go out and build offices, no bricks and mortar. We don't hire clinicians to see patients. We partner with you. So whether you're an independent provider, you're a rural health clinic, an FQHC, you're hospital owned, you're part of an academic medical center, it doesn't matter to us. We partner with all rural practices and their Medicare patients. Our partnership is very much relationship based because we embed inside your practice a new care team member who we call a health navigator. I'm going to talk more about that on the next slide, but health navigators are people who Main Street trains to become Medicare experts. They become insurance experts and really are nimble in being able to solve social determinant of health needs for patients in the challenging setting that often rural healthcare creates. And then finally, we have sophisticated technology that we use to support all of our activities. We have information from health plans, from electronic health record, labs, hospitals, et cetera. And all of that is used to support and direct the work that the health navigators perform. So a little bit more on health navigators. We recruit these people locally from your community. They function very much like a community health worker, only they have this expertise that Main Street trains them to become not only resourceful, but able to give patients advice around how do I think through health insurance? Well, you need to be thinking about network. You need to be thinking about benefits, supplemental benefits, prescription coverage, hospital coverage, et cetera. This person is employed by Main Street. So in other words, it's at no cost to you, but they are there as an extra set of hands in your clinic. And if you look at the list of activities, I've sort of already described these, but think of it as a concierge experience for your patients that they've never had before. Of course, your staff has always been supportive. Of course, they've always been, kind and compassionate. But the fee-for-service world is created such that all day, every day, we have to be moving so rapidly to get from one patient to the next. There isn't often time for this extra handholding. Okay, what's our model? Well, we've already talked about the health navigator, and you can see that their real work is assisting with patient education and value-based care activities such as closing gaps in care, et cetera. But the way that they tee up activities for you as the clinician is through something we call the care coordination assessment. This is a piece of paper. This piece of paper has been developed using unbelievably sophisticated technology tools so that it is unique for every patient. So as you're about to go into the exam room, the health navigator hands you one of our care coordination assessments, and it's asking you to look through a list of diagnoses and confirm or deny them. In other words, thus far in the chart, we've called this patient type 2 diabetes mellitus. Well, what kind of diabetes is it? Is it poorly controlled? Is it well controlled? Is it insulin dependent? Do they have a below the knee amputation? Do they have retinopathy? Do they have nephropathy, etc.? So it's a way to create more specificity for our patients' diagnoses so that we can better tell our patient's story. We have to, represent the patient as either being a very, very sick diabetic or a pretty well diabetic. And that applies to all different diagnoses, whether it's, depression. If someone has, major depressive disorder, is it mild, moderate, severe? Is it in remission? Is it treated? Is it untreated? Do they see counseling, etc.? So we're trying to get at that specificity, because if you go back to the slide where we looked at the new ways we'll be paid, as you remember, in this global payment model, you're paid based on not only the number of patients you have, but the severity of their illnesses. So this assessment allows you to get very specific. Also on the assessment are quality gaps. And so we are able to know which gaps are open because we have health plan data, and the health navigators are there to help get those gaps closed. So whether it's things like mammograms and colonoscopies or things like medication adherence, we know that patients who don't comply with their medications end up in the inappropriate care setting, maybe in an emergency room, maybe they get admitted to the hospital or readmitted to the hospital. Health navigators there to ensure that patients have the appropriate medications and understand how to take those. They're there to assist in transitions of care. We have an admission, discharge, transfer feed. So we know when patients land in an inpatient or emergency care setting, and health navigators are able to immediately get in contact with patients to ensure that they get back in front of you for things like reconciling their medications and or understanding what might be an adjustment in their care plan. And then finally, like I mentioned, they're really helping patients afford care. So if a patient is better suited for a Medicare Advantage plan or an original Medicare, what is their out-of-pocket cost going to be? Do they have any kind of a limited income where we need to, think through affordability of care for patients? This would be net new activities. There are a lot of places who help with, Medicaid and enrolling in Medicaid, which is very important. But this is a very different, net new piece of information for patients, which is help me think through all of the options of Medicare so that I can go back and talk to my loved ones about what makes the most sense for me. I mentioned our technology platform. You can see here the data integration is robust. Outside medical records, the ability to do this coverage and plan compare, like I mentioned, the ability to print and use a very quick and easy worksheet through the care coordination assessment to be able to figure out who are the highest risk patients so that we can engage them proactively. All of this technology is used by the health navigator and by design intentionally, not by you. You don't need another username or password or dashboard, but instead you need someone there to help you figure out what are the actions that we need to take in order to drive this patient's health behaviors to their goals. You can see the integrations are vast. This slide is essentially always out of date because we are adding so many new partners every day. So this is just a brief list that continues to grow. So in short, this is the goal of Main Street Health. We want to partner with you so that you will be well positioned to perform in a value-based care arrangement when Medicare says it's time for all of us to switch. So 4 key things. We want to improve the health outcomes of our patients. So you're already doing a good job. You're already working hard to treat patients every day. But always at the end of the year, we have some percentage of patients who we missed their mammogram or we missed their colonoscopy, or they did end up getting admitted to the hospital. It's that, sort of taking us from good to great or excellent even to perfect, where we're really trying to make sure that nothing gets missed, no stone is left unturned as it relates to the quality and cost of care for this group of patients. We want to help patients navigate the system. We want to make sure that they can afford their care. And then key, we want to reduce burden on you. You and your staff are really stretched. We were stretched before the pandemic, and the pandemic really just added fuel to the fire. We believe that giving you a new member of the care team, one that you don't have to figure out how to pay for, is really important to increase joy in work for you and your team, such that everybody is working at the very top of their degrees and not being bogged down with paperwork around Medicare. Things like prior authorizations, referrals, scheduling, all of that, the Health Navigator can assist your team to sort of reduce the volume of work that they currently have. So what is the scope of our partnership? In some instances, we're partnering with people for only their Medicare Advantage patients, some only their original Medicare patients, and plenty of people we're doing both. In both instances, the Health Navigator would be part of your care team, and we would be helping with this activity once a year to ensure that your problem list is best describing the acuity of your patient's illnesses. And then in addition, the work that we would be doing around quality gaps, et cetera, all of that hinges on the requirements of the health plan. So Medicare Advantage has a very stout list, original Medicare less so, but regardless, either way, we would be ensuring that your activities are aligned with the goals of the health plans and sort of doing that on your behalf to ensure that you are as successful as possible. So the key here is this: we bring you the Health Navigator. We also pay you to complete the care coordination assessment. And then in the instance of our Medicare Advantage patients, paying you a per member per month, a PMPM, for each one of your patients for whom you are accountable and responsible. So I hope what we've described here is a way for you to partner with Main Street such that you have no financial risk, that even better, the finances are moving from us to you such that you can prepare for value-based care. So the question that everybody wants to know, the elephant in the room, well, how in the world are you able to do that? How are you able to make money? Well, Main Street Health, we are partnering with all of the health plans, and they are paying us in that global payment setup so that we are getting the total cost of care upfront. And then we are passing on those dollars and resources to you in terms of the Health Navigator and the care coordination and PMPM assessments. So what we do is we are paying you and taking risk ourselves. No financial risk for you, but the risk is on the side of Main Street, such that if we don't perform, well, we would have to pay back any unnecessary or inappropriate or wasted care dollars. But we believe that through partnership with the Health Navigator, and what our early work has shown us is that this model will ensure that waste is reduced, that quality goes up, patient satisfaction increases, and then if any of that global payment money is left over, we use that money to reinvest in the business. So we would love very much to bring you along our journey toward value-based care and assist you in getting ready for this new world that, frankly, is the whole reason that I went into medicine. I want more time with my patients. I want to be able to see my sick patients longer. I want to be able to manage things telephonically if they could be managed that way. And would love to talk to you more about our experience and my experience as a family doctor with Main Street Health. So thank you so much for your attention, and look forward to seeing you at one of the upcoming ACOFP meetings. Thanks so much.